Hello, everyone, and welcome to Cottage Health's Meet the Doctor event featuring Dr. Michael Paulsen, cardiothoracic surgeon at the Cottage Cardiovascular and Thoracic Surgery Clinic. I'm Christina Cortez, the Public Relations Manager at Cottage Health and your host for this session. Thank you all for being here today. Before we begin, I'd like to share a few housekeeping items to ensure you get the best experience from our virtual event. At the end of today's presentation, we will hold a brief Q&A session. Please click the Q&A button at the bottom of your screen to submit any questions you might have. Please also note that this session is being recorded, so you'll receive an email within the next week with a link to watch the presentation again, along with the PowerPoint slides. It's now my pleasure to introduce Dr. Paulsen. Dr. Paulsen received his medical degree from the University of Michigan Medical School. He completed his residency in cardiothoracic surgery at Stanford University, where he also completed a postdoctoral research fellowship and instructorship in advanced cardiothoracic surgery and transplantation. Dr. Paulsen's research focuses on translational cardiovascular biomechanics, specifically in the area of valvular heart disease and the optimization of surgical repair techniques. Dr. Paulsen has an active clinical practice focusing on complex mitral and aortic valve repair, thoracic aortic surgery, and minimally invasive surgery. He has co-authored over 50 peer-reviewed publications and holds multiple patents related to cardiac surgical devices and research. With that said, please join me in welcoming him.
Thank you so much, and thanks everyone for joining today. I'm going to share my screen and we'll get started. So again, my name is Mike Paulsen. I have no disclosures. There are a few slides in the talk that contain some surgical images and videos, and I'll warn you before we show those. Again, this is just about me. Born and raised in Michigan, went to the University of Michigan, and then I trained at Stanford.
Dr. Paulsen, we can't see your screen. Can you please share your screen?
Yeah, let me try to do that again. I'm sorry.
Thank you.
Is that better?
Perfect. Thank you.
Okay, sorry about that, everyone. So this is just what she went through. This is also about me. So I'm married. I got 2 kids. I have a daughter and a son. My son is 6. My daughter is 4. And we also have 2 dogs, as you can see here, which are pretty outrageous animals. My philosophy of care is pretty simple. I treat every patient like a member of my family. So I just kind of think to myself, what would I want for my mom or my dad or my brother or my wife? And that's kind of what guides me in deciding how to treat patients. And I think that is a good way to do it. So just briefly, what is cardiac surgery? So cardiac surgeons, we treat diseases of the heart and the great vessels. So some of the operations include coronary artery bypass grafting, which is probably the best known. That's where we take vessels or arteries and we bypass blockages in the heart, as you can see on that diagram there. We also repair heart valves. So there's 4 heart valves in the heart, the aortic mitral valve on the left side and the pulmonary and the tricuspid valve on the right side. The most common valves that we fix are the aortic and the mitral valve. We also fix aneurysms of the aorta. So that's when you have a bulging of the artery, and we replace those with a graft material to prevent further aneurysm formation or dissections or ruptures. We also treat congenital heart defects. So if there's defects in the atrial septum or the ventricular septum, we repair those along with any number of anomalies that people can be born with. We also treat heart rhythm disorders. So folks with AFib, we can do procedures to help with that. And lastly, we treat heart failure with mechanical support or heart transplantation. Traditionally, these are performed with the heart-lung machine through a sternotomy, but a lot of these operations can now be performed minimally invasively, which we'll talk about in just a moment. And the ultimate goal of what we do is to restore normal heart function and relieve people of their symptoms and overall improve the quality and quantity of life. So this is just a brief agenda of the topics that we'll cover today. So we'll start off by talking about minimally invasive techniques for aortic and mitral valve repair. And then we'll discuss how we treat aneurysms and how we can spare the valve when we do so. Then we'll go into hybrid surgical approaches to the aortic arch and descending aorta. And then lastly, we'll touch on newer transcatheter-based approaches and the importance of the heart team in deciding what best treatment to offer. So starting off with minimally invasive cardiac surgery. So normally cardiac surgery is performed through sternotomy, which is where we divide the breastbone and you spread the chest and do it that way. We get a great view of everything and can do basically any operation through a sternotomy. And the sternotomy incision is well tolerated by most people. When we think about what causes pain during surgery is usually when you cut through muscle. And with a sternotomy, you go through the skin and a little bit of fat and then the bone, but not a whole lot of muscle. So I think patients are really surprised to see how well tolerated the incision is. And I think, having an abdominal incision or a cesarean section is probably a lot worse from my experience in treating patients. But with that, we can do smaller incisions, which can be better tolerated and have less pain and have a shorter recovery time. And for cardiac surgery, those smaller incisions include for the mitral valve, we'll go through a small mini thoracotomy on the right side where we go through the rib spaces and do about a 2 to 3 inch incision, or we can do a partial sternotomy, an upper partial sternotomy for an aortic valve replacement, where you make about a 3-inch incision and then you just divide a portion of the breastbone and then you leave the bottom part intact, and that can be helpful in healing and in pain as well. And it's kind of sort of counterintuitively, some minimally invasive approaches can actually improve the exposure for a surgeon. So for a mitral valve repair, for example, when we go through a sternotomy, the mitral valve is kind of on the back side of the heart, and you have to rotate the heart over and then use retractors to kind of see under everything and look at the mitral valve. And it can actually be pretty tricky to see the mitral valve. And so a bigger incision isn't always easier, despite what a lot of people would think. And when we do a minimally invasive approach, for example, for the mitral valve, we go in through the side and you get a perfect on-face view of the mitral valve, and it makes repairing it really easy to see. It is a little trickier because it's farther away and the incision is smaller, so you have to use specialized long instruments and a camera. But the view itself is actually quite remarkable. And I'm actually going to show you a couple of videos of some minimally invasive mitral valve repairs, and you'll see how good of a picture we get and how well we can see the valve to repair it. So this is just a pretty straightforward case of a mitral regurgitation where we're testing the valve here, and you could see all the water coming back towards us. It's leaking because the leaflets are kind of, the annulus, I'm sorry, is kind of stretched out. So what we do is we start off by putting sutures circumferentially around the annulus, which is the fiber structure that supports the mitral leaflets. And that's what we've done here. And then I'm testing it again once those sutures are in and pulling up on the sutures to kind of simulate what the annuloplasty ring will do. And you can see there that already the valve has stopped leaking. And the next thing we do is we size it for the appropriate size ring. And the ring is a support structure to support the annulus and provide the proper shape for the valve. And once we've done that, we put the ring in there with those sutures and we tie them down. We go all the way around. And what this ring does is not only kind of shrink the annulus a little bit, but again, it has a particular shape that is designed to optimize the closure of the mitral valve and support it. And so once all of these are tied down, we'll test it again. And you can see here, we have an excellent result, and there's no leakage of the mitral valve after we've done this repair. And this is a very straightforward repair. All we had to do is put the ring in. We didn't have to do much more work. And you can see there's perfectly competent valve. And then we'll put the sucker in there and just kind of to show that it's under pressure and all that water splashes out to demonstrate that it's a competent mitral valve. And so again, that was an easy mitral valve repair. They're not always so easy. They can be quite difficult, actually. Here's another example. This patient had prolapse of both leaflets. So the anterior and the posterior leaflets are both kind of coming into our face, and you can see the leakage there. And what we have to do in this case is actually replace some of the support tendons that help keep the mitral leaflets at the proper position. And that's what we're doing here. And these sutures are made of Gore-Tex, so Teflon basically. It's the same thing that your raincoat's made out of. It's super strong. It doesn't stretch. It doesn't break. And it's a perfect material to replace those cords. And you could see in some of these images, the broken cords. So sometimes in patients, those tendons will break, and that's what causes the leakage. So once those sutures are in place, then we'll again put the ring in there to support the valve and tie those down. And then the next thing we need to do is set the height of those new cords, those new tendons. We want them at a proper height to allow the mitral valve leaflets to coapt and come together without leakage. And so we'll pressurize the valve, and then we'll adjust the height of those leaflets actively with the valve under pressure, so we get it just right, so the leakage stops. And we go, systematically through there. And then this is just a marker that we use to measure the coaptation depth. And you can see you want about 10 millimeters of leaflet below that purple line, which we have. And then we'll do a final test to see how it looks. And again, there's no leakage, and we have a great result here. So this is why I like doing the minimally invasive approach, because not only is it, I think easier for the patient with a better recovery, but you get a great view of the mitral valve. And so it makes it a little easier for us. Just a couple, things to mention. I think with mitral valve disease, we're having thinking about things a little differently. In the past, we would watch mitral regurgitation, and we would only operate on patients once they developed symptoms. But some studies have been performed that compared early surgery to continued watchful waiting. And what we found is that the patients actually do better when you operate on the heart before they develop symptoms, and certainly before the heart starts to remodel. When the mitral valve leaks, the way the heart compensates for that, the body needs a certain amount of blood. So say your heart beats 100 milliliters of blood per heartbeat, and your body needs 100, but if 50 milliliters is going backwards and only 50 is going forward, the way the heart compensates for that is it pumps 150. It gets bigger, and it gets dilated, and it'll pump 150. So 100 goes forward, 50 goes backwards. And the heart can do that for a decent amount of time, but eventually the heart will get too big. And then it won't be able to keep up, and then patients get symptoms and heart failure. And if you repair the mitral valve before the heart dilates, then you can prevent that remodeling, and long-term outcomes have been better. And so the guidelines now show that it's indicated to repair severe mitral regurgitation even in the absence of symptoms. And again, this is the study I mentioned that compared early surgery versus medical management. And you can see, at 20 years, the difference in survival is considerable. So because of this, that's why our guidelines have changed. And we're now operating on patients before symptoms develop if they have severe MR, and they do better. Minimally invasive approach is also really well suited for a host of other procedures. So again, we can do the aortic valve. We can also fix the tricuspid valve. We can fix atrial septal defects, which are holes between the left and the right atrium. And we can also take out, cardiac tumors through this approach as well. So the next topic I want to talk about is the valve sparing approaches to the aortic valve and the aortic root. So another big thing that we do a lot in with cardiac surgery is aortic surgery. So patients that have aneurysms of the aorta, that's when it dilates, and the vessel gets larger than it should. And as the aorta gets larger, you're at a risk for an aortic dissection or an aortic rupture, which is a catastrophe. That's a surgical emergency, and it's associated with a really high mortality rate, and it has to be fixed immediately. And so the name of the game with aortic aneurysms is actually prevention of a dissection. So we want to repair the aorta before it dilates. And when we're dealing with the aortic root, traditionally, if you have an aortic root aneurysm, and the aortic root is the lowest part of the aorta when it comes right off the heart. So it includes the aortic valve and where the coronary arteries come off. And traditionally, the way that we would repair the aortic root aneurysms is we would do an aortic root replacement, also called a Bentall operation after the person that invented it, using a valved conduit. And it kind of looks like this. And in this operation, the aortic valve and the entire aortic root is removed and replaced. and it treats the aneurysm exceptionally well. But the problem with it is that it removes the native aortic valve, which a lot of times is healthy, especially in patients with connective tissue disorders. And you hate to take out a healthy aortic valve because you have to replace it with either a bioprosthetic valve or a mechanical valve, which doesn't last as long for bioprosthetic valves, or a mechanical valve. Patients have to be on blood thinners for the rest of their lives. And so the two surgeons in the probably early to mid 90s started to experiment and have developed some valve sparing approaches to aortic root aneurysms. And these operations, you spare the native valve and then you just replace the diseased aorta. And that way you leave a patient with their native valve, which if done well can last them the rest of their lives. There's two big flavors to this. There's something called the remodeling technique, or the Yakub operation, after the surgeon, Dr. Magdi Yakub. And in this operation, the valve and the sinuses of Valsalva, which are the kind of bulging out pouchings of the aortic root, are spared. And a lot of people think that preserves some flow and biomechanics, but it leaves some diseased aorta in place, which can further dilate. And so that's why the preferred approach now is the reimplantation technique, also known as the Tyrone David operation, after the surgeon that came up with this idea. And that replaces the entire aortic root, and then we resuspend and reconstruct the aortic valve inside of that conduit that you see there. So there are actually, to kind of get the benefits of both, people have tried to develop these novel conduits or grafts to use that can mimic the native shape of the aortic root. And so this includes a Valsalva graft, which is thought to mimic the shape of the Valsalva sinuses of Valsalva and preserve some of the biomechanics. And when I was at Stanford, we did some research into this because we were perplexed by some disparities in clinical outcomes that we saw, whereby the straight graft, which doesn't mimic nature at all, seems to have better long-term outcomes. So the greater freedom from reoperation and less regurgitation of the valve. And so we were trying to figure out why that was. And so we did a study on looking at that. And what we found is that the shape of the Valsalva graft, it doesn't actually mimic the aortic root perfectly. It's a sphere, whereas the aortic root is more of a clover-shaped structure. And because of that, you have this radial displacement of the commissures, and we found that the leaflet velocities and the forces on the leaflet, they were higher. And we thought that was what contributed to the higher rate of degeneration. And we took that a step further, and we looked at all of the various conduit options that are available. And there's 5 or 6 of them. And so we looked at every single one of them. And we published this in the journal Circulation. And I'll just kind of go through briefly what we found in our method. So we used 3D printing technology and created a left heart simulator to test this on the bench outside of the body. And that's what this looks like here. And this allowed us to simulate what's going on inside of the heart and experiment with these different conditions. And then we used pig aortic roots, and then we basically performed the operation with all 5 of those conduits on 5 of these valves and a counterbalanced design, and then we compared it. And this is what it looked like inside of our simulator with all the various graft choices. And this is what it looks like from above. You can see high-speed video of the valves opening and closing. And we studied how quickly those leaflets were moving. We studied the flutter and the turbulence. And what we found was actually pretty interesting and not what you would expect. Again, we found that the straight graft, which doesn't mimic nature whatsoever, it doesn't recreate those sinuses of Valsalva, it was the best. It had the lowest regurgitation fraction. It had the lowest cuspal velocities and the lowest forces. And so that's why we think the long-term outcomes are better, and it has a better longevity. And for that reason, when I do this operation, I just use a straight graft, and that's what it looks like when we do it in the body. And you can see here the conduit, the Dacron conduit, it replaces the aneurysmal aorta, and we've reconstructed the native aortic valve inside of that graft to provide an excellent outcome. And this is what the echo looks like afterwards. You can see the aortic valve is opening and closing perfectly, and there's no leakage. And so we took care of this patient's aneurysm and also preserved their native valve. And so one of the big questions we have is, when should we operate on aneurysms? And the way we decide is we look at the natural history of aortic aneurysms. So, surgery has risks. Every operation has a risk, and with an aortic surgery like that, we generalize the risk to be about 1% chance of something bad happening. And so when you look at aortic aneurysms, on the left side of this graph is the annual risk of an aortic dissection or an aortic rupture in a year. And on the bottom is the size of the aorta. And what we find is that when your aorta is 4 to 4.5, or even under 5 centimeters, the risk of a dissection or a rupture in 1 year is less than 1%. Less than the risk of surgery. And so when it's under 5, we just continue to watch and wait because that's a safer option. But once you get to 5 to 5.5, then the risk of a dissection or a rupture goes up considerably to, between 2.7 and 8.1%. That's the conservative range. And then as it gets larger, it increases the risk even further. And so because of that, the point at which we decide to offer surgery is generally 5 centimeters or 50 millimeters. Because that's when the risk starts to go up. And what we want to do is prevent dissections and ruptures. And the next topic we'll talk about are hybrid surgical approaches to the aortic arch and the descending aorta. This is where a lot of technology is rapidly evolving. So when you have an aortic arch aneurysm or a descending aortic aneurysm, you have to do an aortic arch replacement, which usually requires a 2-stage operation. First, you do the aortic arch, where you replace the part of the aorta that feeds the head vessels, the brain, and the arms. And then you have to do a stage 2 operation, or a thoracoabdominal aortic surgery, which is to replace the rest of the aorta for these big aneurysmal aortas. And this is a highly morbid operation. You make a massive incision. It's like 2.5 or 3 feet long. It's extremely painful, and it's just highly morbid, difficult recovery. And it's also hard to do. It takes about 12 to 18 hours. And so it's kind of miserable for everybody involved, the patient, the surgeon. It's not a fun operation to do. And so luckily, there are these new techniques that we can do. And we can do stent grafts, which are catheter-based interventions where you have a stent that's covered with usually Teflon or Gore-Tex, and we put it up in a catheter, and then we can expand it inside of that aorta. And instead of having to do surgery, we can replace the aorta with the stent graft. And this works really well for the descending aorta, and we can even do it on part of the aortic arch. We cannot yet do it for the entire aortic arch, and we unfortunately cannot do it for the ascending aorta, where you have a dissection risk just because of the anatomy and the movement of the heart in that area. But for the descending aorta, it works really well, and it's much better tolerated than a thoracoabdominal aortic surgery. And this is what it looks like once you're done. So the stage 1 operation would be partial arch replacement through a standard surgery. But then instead of that thoracoabdominal surgery, we can then do the stent graft approach, which looks like what we see here. And we've done several of these at Cottage, and this is what it looks like on X-ray. So on the left side, you can see that's before the stent graft gets deployed. It's up in the aortic arch, and we position it with X-rays, and then we deploy it, and then you can see it kind of expands open and pops open and excludes the aneurysm, basically. And it works really well, and it's extremely well tolerated. And it's a lot easier to do as well. All right. And then lastly, I just wanted to talk about transcatheter-based approaches and the importance of the heart team. So this is the other area that's rapidly evolving in heart surgery, and it's really fascinating to watch. So the two main things that we are developing with catheter-based procedures are transcatheter aortic valve replacement, or TAVR, TAVR. And that is where we use a catheter. We go up through the groin typically, and we put in a wire, and then we put this valve, which is collapsed down. We put it into position, and we use a balloon to inflate it and pop it open. And so you can replace the aortic valve without surgery. And it works extremely well. It's less invasive, no sternotomy, faster recovery time. Patients usually go home in a day or two. But it's not 100% perfect. There are some downsides. One, we don't really know about the durability. It's a new technology. It hasn't been around for very long. And so we're not sure if it's going to last as long as the surgical replacement valves. And also it's less suitable for patients with bicuspid aortic stenosis. That's where you have only 2 leaflets in the aortic valve. Normally we have 3, but the most common congenital heart defect, about 1% of the population has it, is a bicuspid aortic valve. And the TAVR is not as good for that. But overall, it's an excellent option for high-risk patients and older patients. But surgical AVR is preferred in younger patients. And the reason for that is because, in someone that's young, if you're 50, 60, 65, you're going to live to be 85, 90, maybe more. The TAVR probably only lasts about 10 years. And so to get you through to 90 or 95 or 100 years, you're going to probably need 2 valve procedures. And if you do a TAVR, you can sometimes do a valve in valve, go in later and put a TAVR inside of a TAVR, at least on paper. That seems like it could work, but what we're finding in practice is that it doesn't always work. And if you have to do a TAVR and then surgery later, that's actually the most commonly growing operation that we're doing. And it's unfortunately pretty high risk. And on a nationwide average, the mortality rates are around 10 to 15% if you have to take a TAVR out and put a surgical valve in. And the reason is because when you expand that TAVR valve, it kind of destroys the aorta. And so you generally have to replace the aortic root. And it's usually on a patient that's older because, they get a TAVR when they're 70 and now they're 80 something, and they need this big redo operation. And it's not ideal. And so what we found is a better strategy if you're going to need 2 valve interventions is to have surgery when you're younger. We can put a huge surgical valve in that's designed to accommodate a future TAVR. It's built with these expansion joints that can accommodate and expand for a TAVR, so you get a nice big valve in later. And when you're young and healthy, the risk of an aortic valve replacement is less than 1%. It's probably less than 0.5% in terms of something bad happening. And then doing a valve in valve TAVR later inside of a prior surgical aortic valve is also extremely safe. And because of that, the guidelines would support that as well, that TAVR should be reserved mostly for patients that are prohibitively high risk and older. Despite that, TAVR still represents the majority of aortic replacements in patients less than 65. And so even though the guidelines advise against it, understandably, if you're presented with a choice between the catheter-based procedure or, open surgery, everyone's going to go with the catheter-based procedure if they don't understand the background and understand the data. But I think it's important to understand those things and the implications of it and have your future self in mind when you make this choice. Because as you see here in patients under 65, this is a study out of Cedars-Sinai that looked at a propensity matched cohort of patients under 65. And you can see there's a marked survival difference in patients with surgery versus TAVR as their first procedure. And it's considerable. It's almost like, the difference between having stage 1 cancer and, stage 4 cancer almost. At 8 years, the survival is marked. And so I think it's important to have a full understanding of the implications of not only the procedure you're having at that time, but what the future is going to entail. And for younger patients, I think you really have to plan for having kind of a lifelong management of your aortic valve, and you'll probably need 2 procedures to get you all the way to 95 or 100. And the order and which type of procedure I think can have a big difference. And then the other, technology that is being developed is called a transcatheter edge-to-edge repair, or a MitraClip, to treat degenerative mitral regurgitation. And this operation is also catheter-based, and there's a clip, and it goes and clips the 2 mitral leaflets together. It's used for mitral and tricuspid regurgitation. It's less invasive and offers a faster recovery, but it is 100% clearly inferior to surgery. It's based on what's called the Alfieri stitch, which is the first repair technique that we invented for mitral surgery, and that's where you sew the anterior and posterior leaflets together, and it helps regurgitation, but it severely narrows the orifice of the mitral valve. And so instead of having one big opening that blood fills the heart with, you narrow it down to two little ones. And so you generally leave patients with, and you fix some of their mitral regurgitation, but you also leave them now with, they have mitral stenosis, which also causes symptoms. And because of this, it's not a good operation. We never do it ever in modern mitral valve repair surgery. You'll never see a mitral surgeon do an Alfieri stitch in an open mitral valve repair. And so the MitraClip really should be reserved for patients who are too high risk for surgery. If you have degenerative or functional mitral regurgitation, that means there's something wrong with the mitral valve itself. Now, if you have mitral regurgitation due to, heart muscle disease, cardiomyopathy, either from coronary disease or, genetic cardiomyopathy, that's a different story. The MitraClip can be a better option in some cases, but for primary degenerative mitral regurgitation, surgery is clearly better if you're not excessively high risk. And that's what the guidelines also say. The only time that the guidelines would ever recommend a MitraClip would be in high or prohibitive surgical risk patients. And then for secondary or functional MR, it's really only in patients with severely reduced ejection fractions. Even with a secondary MR or functional MR, if you have a normal, pretty healthy heart, surgery is also still recommended because the outcomes are better. And this is another study that shows it. And, despite the guidelines, the use of a MitraClip or TEER in primary MR is rapidly increasing. And I think inappropriately. I think we're doing patients a major disservice by doing this. And in this chart here, you can see on the left-hand graph, this is the number of cases, mitral cases. So either transcatheter mitral cases, surgical repair, or surgical placement. And if you add all those up over the years, the total number of mitral interventions has been the same. So it's not growing, but you can see that the breakdown is changing. And so this transcatheter approach is rapidly growing up, and repairs and replacements are going down. And that comes at a huge cost to patients. You can see here, survival difference is considerable when you talk about MitraClip versus surgical repair. Surgical repair is much better than a MitraClip. And so, I think it's important when you have a tool, like a hammer, you can't treat everything like it's a nail, because it isn't always a nail. And the same goes with surgeons. I would, probably bias towards surgery, just as the folks that do the transcatheter approaches are biased towards those. But I think we really need to, come together as a team and think about the patient's best interest when we do this. Just because you can do something doesn't mean you should do something. And that's where the heart team approach comes into things. And that's what we do here at Cottage. And it's, founded on interdisciplinary collaboration between the specialties. And so at the center of this is the patient, you, and then around you is the whole team. And so that includes a surgeon, a cardiologist, interventional cardiologist, anesthesia, the radiologists, our clinic coordinators. And I think it's important that we strictly adhere to guidelines and make sure that the decisions are evidence-based, with shared decision-making involving the patient, making sure that they are aware of the data and all the implications. And I think with that, we can achieve optimal treatment and optimal outcomes. And that's really why we do what we do. And so I think that is a really critically important piece of how we're treating patients. So with that said, that's all I have, and I wanted to leave plenty of time for questions. So at this time, I'd be happy to answer any questions anyone has.
Thank you, Dr. Paulsen, for that very informative and interesting presentation. We're now going to move into the Q&A session. So I'm going to start off with our first question. Just a reminder to everyone, please put your questions in the Q&A box at the bottom of your screen, and I'll read them off to Dr. Paulsen. So we'll start off with our first question, which is, what are the main benefits of minimally invasive cardiac surgery compared to traditional surgery?
That's a great question. So again, as we mentioned, the benefits of minimally invasive cardiac surgery are a smaller incision and oftentimes less pain, faster recovery. Patients generally go home in a shorter amount of time, and then the total recovery is usually more expeditious. And then also, in some cases, I think it's an easier operation for us to perform oftentimes.
Okay, perfect. Thank you. Our next question is, can anything be done about a high calcium deposit score in the LAD other than beta blockers?
So if you have a high calcium score in the LAD, depending on how high, I think the important thing for that is to talk with your cardiologist to see if you need a coronary angiogram. A high calcium score is typically a marker of atherosclerosis of the coronaries, and the reason we do these calcium scores is it's a screening test to see if you're at risk of coronary disease or blockages. And if so, then you would want to get an angiogram, which would look at if there are blockages. And if there are blockages, then it would be wise to think about some kind of intervention on that, either bypass surgery or stenting to clear those blockages and prevent a heart attack. As far as beta blockers, that's more of a kind of a preventative thing, but I think the more important thing is to rule out coronary disease.
Okay, thank you. Our next question, can an aortic mechanical valve be replaced if needed?
Yes, it can. And so that's actually a great question and brings up a good topic. So when we do replacing of valves, we try to repair valves. That's the best thing to do, is to repair and keep your native valve. But in some cases you can't. And that's particularly true with the aortic valve. The most common reason that we intervene on an aortic valve is because of aortic stenosis. And as we get older, it happens to all of us, our tissues kind of calcify and it doesn't work as well. And so if you live long enough, most of us are going to need an aortic valve replacement. And if you have a, bicuspid valve or whatnot, it can happen sooner. But when you do a replacement, there's two valve choices for surgery anyway. There's a mechanical valve and then there's a bioprosthetic valve. And the bioprosthetic valves, you don't have to be on a blood thinner, but they don't last as long as mechanical valve. Mechanical valves are supposed to last forever, but you have to be on blood thinners. But they don't always really last forever because the body still kind of deposits tissue on the mechanical valve, and so we do replace them. And the answer is yes, you can replace a mechanical aortic valve if needed. It's kind of the same as replacing a bioprosthetic valve if we have to. It's a little bit more challenging than doing surgery the first time because it's a redo operation. So you have to go through some scar tissue and just kind of take your time and be safe and be careful. But we can do that certainly and without a problem.
Okay, great, thanks. What about using pig valves for replacement?
Yeah, so those are the bioprosthetic valves, and they're pig or cow usually, and it's actually a lot of people think it's like the actual valve from a pig or a cow, and it's actually not. Usually, it's the pericardium from a cow or pig. Usually, a cow actually. It's bovine pericardium, and so what they do is they take the pericardium, and that's the sac around the heart. It's this fibrous sac. And they take the pericardium from cows and they kind of wash it, clear out all the cells so that it's not immunogenic. And then if you actually go to the factory, it's amazing. They have these, they're all handmade by like seamstresses and I don't know the other, male gender for seamstress, but people that specialize in sewing. And it's like, it's like, your grandma, basically. Those are the people that are best at sewing, and they're under these microscopes sewing these valves. And I think each valve has like 2,000 stitches in it. It's amazing. So that's what they use to make these valves. And yeah, it's remarkable how well they are designed and work.
That's pretty impressive. Thanks for that. Now I want to see a picture.
Yeah.
One of our questions is, if someone had an aortic valve replacement about 12 years ago of a bicuspid valve, would it be a candidate for TAVR?
Potentially. So when you have a surgical aortic valve replacement, and if you had it now, the valves that we use today are designed to accommodate a future TAVR, and that's the goal. If you had a valve done 12 years ago, it depends on the kind of valve that they used and how big it is. Some of the older valves can accommodate a TAVR, especially if they're big, but not always. It's not always guaranteed. if it's too small, so if the surgical valve that was placed is not large enough to accommodate a TAVR, then what can happen is because when you do a valve in valve, you have a circle, that's the valve annulus. And when you do a TAVR, it has to go inside of that circle. So it's going to get smaller because it has to take up some space. And depending on how big you are and how tall you are, how much you weigh, you need a certain size valve so that you don't have symptoms. And so you have to kind of look at the size and the type of valve to see if a TAVR would work and would be big enough. But hopefully you could, and that's what the goal would be, certainly.
Okay, great. For stents, what are they are all stents implanted through a minimally invasive technique, or does it vary?
So for stents, I'm not sure if they're talking about coronary stents or those aortic stents I was telling you about, but yes, usually it's minimally invasive. For some of the aortic stents, we have to make some small incisions, like in the axillary region sometimes, but it's mostly minimally invasive through kind of just a percutaneous or a needle stick kind of exposure.
Okay, great. Should ablation be used to enhance heart function or only for symptom reduction?
Both, actually. I think ablation, depending on what the arrhythmia that a patient has, it can do both things. It can help with not only symptoms, but also can help with heart function as well. And that combined with, placing pacemakers, we know can help considerably.
Okay, thank you. To your knowledge, are there individuals with ball and cage valves still around?
I've seen a few, actually. That's an interesting question. So, for those that are unfamiliar, the first valve, probably the first valve actually was a ball and cage valve. So it's basically a cage with initially it was a metal ball, and so when the heart beat, the ball would fly upward, and then when the heart wasn't beating, the ball would fall down and kind of block the hole. And those valves were extremely loud. Actually, I don't know if this is true or not, but anecdotally, there's been reports of patients like killing themselves because it was so loud and you could like hear it from the door. So we don't use those anymore, luckily. But I don't know if anyone still has them. I mean, the Star Edwards valve, I think, was a ball and cage valve, and that was invented in the early 60s, I believe. So I guess if someone had it done as a child, maybe they're still around. But I saw one or two when I was in training, like my first or second year. That would have been over a decade ago now. So I don't know. There's probably someone around with it, but I haven't seen one in a long time.
Okay, thank you for that. When it comes to TAVR, are there different types of TAVR valves, like different makers of the valves?
Yeah, there are. So TAVR could broadly be divided into two types of valves. So there's a self-expanding TAVR valve. So that's like it basically springs open on its own. And then there's a balloon expandable TAVR valve. That's where we inflate the valve with a balloon. So those are the two main types. There's several manufacturers. The big two that we are familiar with mostly for the self-expanding valve is Medtronic, and for the balloon expandable is Edwards. Here at Cottage, and we prefer the balloon expandable ones. They seem to work better. They're associated with a lower pacemaker risk. They're lower profile, and I think they're easier to place. But the technology is rapidly changing, and so I'm sure that in the next 5 years, someone might come out with a different one that's better, or even a different kind. So it's always changing.
Okay, thank you. Shifting a little bit, since COVID, it's been 5 years now, have you seen a significant increase in coronary artery disease and valvular stenosis?
No, I don't think the incidence has changed much. During COVID, we actually saw a drop of patients with these diseases because people weren't going to the doctor, weren't going to the hospital, and so there was a lull for sure. And then there was, I think, kind of a bump in cases where there was a little catching up to do, where right afterwards you saw a little bit more because people hadn't been going to the doctor, but I think that's evened out. The one thing that was interesting is we saw less dissections during COVID, which is kind of sad, really, because the incidence of how frequent dissections happen doesn't change. So I'm sure that patients were still having dissections; they just weren't going to the doctor, which was unfortunate.
Mhm.
But yeah, I haven't seen much of a difference. It's been pretty stable.
Okay, great. What is and I don't know if you have this number at the top of your head, but maybe you can speak a little to it. What is the success rate with ablation for AFib?
I don't know off the top of my head the difference between ablation and I mean, I know some numbers for the surgical equivalent of that. So when we do surgery, we do what's called a maze procedure. And if you do a full maze procedure, you could get success rates of around 85, 90% with a full maze. I don't know what the results are for the catheter-based ablations. But with a surgical approach, you can get really good AFib results.
Okay, thanks. How soon after minimally invasive heart surgery can patients usually return to their normal activities?
That's a good question. Usually, so with a sternotomy, um, we usually advise patients to kind of take it easy for 6 weeks to allow the bone to heal. And you could do most things afterwards. I mean, patients are walking the day after surgery, and really it's just like heavy lifting. You can't, no bench pressing, no push-ups, stuff like that, because you want the bone to heal. But walking and doing, showering and doing all your activities of daily living, patients can do, right afterwards. Minimally invasive surgery, I think patients get back to doing some of those more vigorous activities more quickly, like doing lifting weights or riding a bicycle. And I think probably 2 to 4 weeks would be a safe on average. It's not everybody. I mean, sometimes if you have complications or setbacks, it can take longer. But on average, I would say most people are back to doing what they're doing, 2 to 4 weeks after the minimally invasive approach versus 6 to 8 with a traditional sternotomy approach.
Okay, thank you for that. You touched a little bit upon this towards the end of your presentation, but can you talk a little bit more about what a heart team is and why it's important for cardiac patients to have a heart team?
Yeah, absolutely. So the heart team again is this collaborative approach between the interventional cardiologists, the surgeons, patients, the referring cardiologists to kind of help come up with the best plan. Because like I said, there's intricacies with this. And so, the gray zone. So if someone's 90 years old and they need an aortic valve replacement, TAVR is obviously the best choice for them. Or 100 years old, you're going to do a TAVR. You don't want to do surgery on them. It's going to be hard, and they probably aren't going to tolerate it very well. And if you have a 50-year-old, they should have surgery. They should not get a TAVR. Even a 60-year-old or a 65-year-old should have surgery because they're going to need another procedure down the line. And the safest, best approach is surgery followed by a TAVR. When you get into the gray zone is when you're 70 or 75. But as we know, it's not always about a number. It's all about your physiology. And we joke about this, but if you're really some 75-year-olds are healthy, they don't look 75 or they don't look 80. And here at Cottage, you just joke like, oh well, this guy's he's a Santa Barbara 75. Or at Sanford, we say, oh, they're a Palo Alto 75. They're a good 75. They don't look 75. They look more like 60. And in that situation, you have to think about, physiologically, your age is 75, but physiologically, maybe your body really only, it seems like it's, in its 60s, and maybe your folks live to be 100, each of them. And you really have to think it's different. Then I think you have to have the heart team kind of help guide you, and they have to have your best interest in mind, not their best interest in mind, what procedure they prefer to do. It's all about what is best for you. And if you're, 70 or 75 and you're in excellent health, and your folks live to be 95, 100, then it's probably in the realm of consideration that you're going to need, again, probably 2 valves to get you through your whole life. And so it's important to kind of have a good strategy about how you're going to get through those two procedures and what's the safest way to do it. And, doing a TAVR now and then trying to do a TAVR later might not work. And so you don't want to do a TAVR now and then have to have a surgery when you're 85. And in that situation, it's probably better to have a surgery now, a low risk surgery, and then plan to do the TAVR later. And so that's what the heart team, I think, can help patients navigate, at least in theory and in an ideal setting.
A great explanation. Thank you for that. This is a interesting question. When is it better to do angiograms and stent placements through the wrist versus the groin?
I don't know the answer to that. I don't do angiograms. That would be a question that a cardiologist could answer, I would assume. I mean, I kind of know a little bit. I think the wrist is preferred. It's better. It's easier for patients, and it's better tolerated. And you don't have to lay. Usually, when you go through the groin, you have to lay flat for 6 hours afterwards. And with the wrist, you don't have to do that. So I think the wrist is preferred if you can. But I guess there are probably some situations where you might not want to go through the wrist. And usually, for your hand to get blood, you have two arteries. You have a radial artery and you have an ulnar artery, and they're connected by the palmar arch. And so if you lose one, you still get blood to your hand through the other one. But not everybody has a complete palmar arch. So if you have an incomplete palmar arch and you go through the radial artery and that artery gets damaged and you lose blood flow, that's a problem, because then half your hand is not getting blood, and you don't want that. You don't want to lose half your hand. And so that's why, the cardiologists, they'll always check for the complete palmar arch before they do that kind of procedure. But I think by and large, going through the wrist is probably better for the patient. But again, I'm not an expert in the angiogram, so I can't definitively answer that, unfortunately.
Okay, thank you. Okay, this is going to be a tongue twister for me, but bear with me. You mentioned connective tissue disorders. When do you do prophylactic procedure, for example, aortic arch replacement?
That is an excellent question. So there are connective tissue disorders, and they come on a spectrum. There are some that are very severe and some that are less severe. The most severe one is probably a disease called Loeys-Dietz syndrome, or Marfan syndrome is another one, not quite as bad. And in that case, patients that have Loeys-Dietz or Marfan syndrome often present with very large aneurysms when they're very young, 20, even younger, in their 30s maybe. And their aortas grow rapidly, and over time, they almost all have dissections. And so we will sometimes, if a patient has Loeys-Dietz or Marfan's or TGF beta mutations, things like that, we will sometimes do a prophylactic aortic arch replacement in those patients. And we actually studied that at Stanford when I was there. They were looking at doing that, and the patients did better in certain mutations with the more aggressive variants of Loeys-Dietz syndrome, and we would do that. But for patients that have sporadic aneurysms, like most patients with aneurysms come in, their 60s or 70s, and it's like kind of what they call a sporadic aneurysm. It probably is genetic of some kind. We don't know what genes it is, and it isn't as a malignant presentation as like with Loeys-Dietz. In that situation, we would not prophylactically do the aortic arch, because that is a much higher risk operation. It's a bigger operation. And I think if you don't really know how aggressive that genetic connective tissue disorder is, it would probably not be wise to do it prophylactically. But if someone has a connective tissue disorder, then you would consider it. Or if someone has a connective tissue disorder and they're female and they want to have a baby, then you might consider it, because we know that pregnancy and connective tissue disorders is dangerous. And so we'll sometimes do that prophylactically.
Okay, thank you for that. Next question, is there a direct correlation between TAVR versus age for the need of pacemaker? If so, why? What is the reason or need for a pacemaker after TAVR?
I don't know that age is a consideration. The big factor with pacemaker need after TAVR there's two things actually. One is if you have a pre-existing rhythm or conduction abnormality. Everybody before TAVR gets an EKG. And some people with things that are like a right or left bundle branch block, you're at a higher risk for needing a pacemaker after TAVR. And then the other big thing with TAVR is the kind of TAVR we use. And that's probably the biggest reason we don't like using the self-expanding TAVRs is because they're associated with a much higher risk of pacemaker placement, whereas the balloon expandable ones are not as much. You certainly can, but it's a lot lower, whereas the self-expanding TAVRs are associated with a much higher risk of pacemaker placement. But age itself, I don't think there's a correlation between age necessarily.
Okay, thank you. We have one question. Let's see if you can help me make this one out. What about amyloidosis and heart disease as it relates to heart surgery?
So I guess it depends on how severe the amyloidosis is and what we're trying to treat. Amyloidosis, unfortunately, is not one of the diseases that there are a lot of treatments for. Fortunately, most patients with cardiac amyloid have a pretty mild presentation and they do fine, and it doesn't cause too much of an issue. With patients that have very severe amyloidosis and they subsequently develop severe heart failure, really the main treatment for that is a heart transplant if you have that. But aside from that, there isn't a really great treatment for amyloidosis, unfortunately.
Thank you. I'm glad you understood that one. I think we have time for one last question. So this has gone by very fast. Thank you for all the great information. How do you decide when it's the right time to operate on an aortic aneurysm or a leaky heart valve?
That's a great question. And deciding on timing is crucial. So it depends on what. So for an aneurysm, we look at the size, and for an ascending aneurysm or an aortic root aneurysm, we go on usually 5 centimeters or symptoms. If you have symptoms, then we operate. It doesn't matter how big it is, as long as we determine that your symptoms are from the aneurysm, and that can be a little tricky because it's kind of a diagnosis of exclusion. We got to rule out other causes of chest pain and make sure that that's from the aneurysm. But you can see that usually pain from aortic aneurysms is described as you have a chest pain that radiates to the back. It's usually kind of sharp, and the pain with a dissection is usually like a tearing sensation. And so if you have something that seems aortic in nature, we would replace the aorta at that time, regardless of size, if we're concerned for an aneurysm causing that. As far as heart valves go, it depends on the heart valve. For the aortic valve for aortic stenosis, for example, we operate when patients are symptomatic and have severe stenosis. There are some trials going on now looking at moderate stenosis with symptoms, and that would probably be an indication for aortic regurgitation. Also usually symptoms, or if you start to see the heart dilate and start to remodel in a bad way, we'll generally operate. For the mitral valve, if it's severe regurgitation, degenerative regurgitation, we do surgery even before symptoms and even before the heart remodels. And then for mitral stenosis, it just we go based on the numbers that we get on the echo, how the gradient is, and also with symptoms. So it depends, but that's why in those charts I showed with the various guidelines, that's how we follow those to kind of help us decide when the right time is.
Awesome. Well, thank you so much, Dr. Paulsen. This has been super informative. You went through a lot of great questions. Thank you all for your questions, and thank you for joining us this evening. Dr. Paulsen's office is located at the Cottage Cardiovascular and Thoracic Surgery Clinic on the 2nd floor at 221 West Pueblo Street in Santa Barbara. Immediately following this presentation, you'll receive a link to request more information or have a member of Dr. Paulsen's team reach out to you to make an appointment. We will also email a recording of this presentation later this week. If you have further questions or would like more information, you can always call 805-563-7001. or visit cottagehealth.org/CT. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. So thank you again for joining, and have a happy and healthy rest of your evening. Thank you, Dr. Paulsen.
Thank you very much. Thanks everyone for joining. This has been a pleasure.